So, good evening, ladies and gentlemen. Welcome to another edition of Thoughtful Tuesdays IAPS Webinars. Today's speaker is Dr. Mainak Deb, who's currently the Senior Consultant Pediatric Surgeon at the Rainbow Children's Hospital in Hyderabad. He was previously Professor of Pediatric Surgery at St. John's Medical College Hospital in Bangalore. So Dr. Mainak is somebody who's very well read and a very articulate speaker. So I would hand over to him without much ado to talk on the management of antenatally diagnosed lung malformations. So Dr. Mainak, thank you.
Thank you, Dr. Sajera, for a kind introduction. At the topic, and thank you for letting me speak in this forum. I think very learned people have already spoken on this forum, and it's nice to be able to speak on the same forum as many other well-read people. I'll start off my presentation. I'll start sharing my screen, and please let me know if my screen is visible. I've tried to keep the presentation as simple as possible, with one important point in mind, that the postgraduates who are tuning in shouldn't get too confused with a large array of information that is available on this topic. There was a time when we were students that there were quite a few gray areas in this area of our practice. But as time has been going by and the gray areas are getting a lot more clearer, the protocols are being more and more refined, and there is a sort of temperance in the aggressiveness with which we treat these patients surgically. Also, So as I was discussing with Dr. Sanjay Rao, I just take this opportunity to present the basic facts which are around this topic, lay down a few solid ideas which have already been sort of have crystallized into the treatment protocol, and touch on some of the gray areas which are still prevalent and may lead to a difference in opinion, especially with regards to surgical management of some of these entities. The other gray area is the embryogenesis of these lesions. But if we look at it, and there are quite a few, and the embryogenesis of these lesions are really poorly understood. There are multiple hypotheses. Animal models have demonstrated all manner of different different genetic mechanisms, different modes of different kinds of insults, different methods of mechanisms of action of genesis of these lesions, and yet we are not really clear as to when and how these take place. But from a clinical standpoint, from a management standpoint, at this point of time, I don't think we are it's very important for us to go into the depths of the embryogenesis. We could probably manage our clinical protocol with great clarity, even if we have a superficial understanding of the embryogenesis. And with that background, I'll just start my talk. So, these lesions, these congenitally detected pulmonary lesions, antenatally detected pulmonary lesions, are relatively uncommon lesions, and they're seen in 1 in 10,000 to 35,000 live births, and they include a wide spectrum of disorders. The more commonest ones are the congenital pulmonary adenomatoid malformations, CPAMs, which were previously called CCAMs. I will be probably interchangeably using these terms because CCAM is still a very widely used term, and so we might use the word CCAM during our talk. Pulmonary sequestrations are another entity which are commonly seen, may not require very much active treatment, but are not as commonly seen as CPAMs. The other common entity which we see is a congenital lobar emphysema, a CLE, or what may also be called a congenital lobar overinflation, a CLO. Bronchogenic cysts are the fourth common entity which we will be briefly touching upon on this talk. These present antenatally, have an overlap in their pathology and presentation, and their embryogenesis seems to also overlap over a period of time. So the way they form is also seem to have a common root. So let's quickly revise how the lung and the respiratory tract develop. The respiratory tract development begins around the 4th week of gestation with the laryngotracheal groove forming and the foregut dividing into the respiratory diverticulum and the esophagus. Beyond the 5th week, the primary bronchi have started to develop, the pseudoglandular period has started, and branching of the terminal bronchioles begin from the 5th to 16th weeks. They continue into terminal bronchioles, and the respiratory bronchioles are starting to be seen around 6 to 28 weeks, 6 to 26 weeks in the canalicular period. These are so no alveolar sacs or terminal sacs are seen yet. Alveolar sacs start to appear in the terminal sac period around 26 weeks to birth. And the alveolar period, which starts around 8 months of gestation, continues well into early childhood and in toddlers up to 4 to 5 years of age. And hence, this is the period which is very important when we plan surgical therapy for CPAMs, because a lot of the need for surgery or the justification for surgery in these is based on the fact that mature alveoli still develop in the early childhood and continue into toddler in 4 to 5 years. So maximizing this growth period is one of the aims which can be served by an early surgery in CPAP. Sorry. Okay, having understood the basis of the lung development process, we also need to understand the pathological basis of the various developmental anomalies is poorly understood. They're not clearly defined. There are various pathogenetic mechanisms that have been postulated, and various animal models have been put forward, but there doesn't seem to be any unified hypothesis or theory on how these lesions come about. And these malformations have a significant overlap and they coexist. For example, you might find, pathologically speaking, something that looks very much like a bronchopulmonary sequestration have pathological features of what is classically described as a CPAM. Or many CPAMs present as hybrid lesions with the sine qua non of a BPS or a bronchopulmonary sequestration. That is, some of the CPAMs may present with hybrid features of a bronchopulmonary sequestration, like a systemic blood supply. So there seems to be a wide spectrum. And many people now recognize that there is actually a wide spectrum of malformations, starting from pulmonary artery malformations to bronchogenic cysts, with various types of pulmonary lesions lying in between these spectrums. So one of the most common hypothesis put forward in the pathogenesis of these lesions is possibly an in utero airway obstruction. But the timing of that obstruction or that insult is not really clear. But what we can say briefly, or what we can sort of agree upon, is that most of the time, the CPAM, most people agree that types 1, 2, and 3, we will come to those types later on. The common types of CPAM appear when, or even the bronchopulmonary sequestrations appear when that insult happens in the pseudoglandular phase of the development of the lung. While type 4 CPAMs appear much later in the alveolar phase, so they appear much later in the gestation period with large thin walled cysts, which appear to be alveolar overdistension rather than bronchopulmonary dysgenesis. So, with this brief, or at least a probably not so clear understanding of the embryology, what we should be focusing on is actually the clinical scenarios which confront us when dealing with these lesions. So let's come to a quick clinical scenario. The commonest clinical scenario that confronts us in the OPD or in the office when we are dealing with congenitally or antenatally diagnosed lung lesions. And that is, for example, a 28-year-old primary gravida, and that's exactly what happened to us last week. 28-year-old primary gravida at 28 weeks of gestation came to us with an antenatal diagnosis of a right echogenic lung lesion. There was no mediastinal shift. The lesion had a CVR of 1.2. There was no hydrops. Right. So now, how do we counsel these parents? There are quite a few challenges in counseling. If you understand how CPAM works, or how the natural history of these lesions progress. So there are some lesions which we know would progress in size, increase in severity, and some would regress. So to understand, to offer a meaningful counseling to this parent, we need to probably go back, try and look through what are the facts regarding the clinical course, the natural history, and the treatment options available to us in these situations before we can offer meaningful and effective counseling. So let's then quickly recap what happens in these lesions before we come back to this scenario. And then I will ask people whether or not they think that they would be able to effectively counsel these parents. So let's start with one of the most common conditions that we notice in these children, or one of the most common antenatally diagnosed lung lesions, and that is a CCAM or a CPAM. So the name congenital pulmonary adenomatoid malformations has been espoused as a replacement for congenital cystic adenomatoid malformations recently. These are hematomatous malformations, probably formed because of abnormal branching of immature bronchioles in the pseudoglandular phase, somewhere between 7 to 27 weeks of gestation. They have some typical microscopic features. They have polypoid projections of the mucosa. The smooth muscle content within the cyst is increased. And one important feature is absence of cartilage within the mass. So for the postgraduates, remember, that is one of the important features of a congenital pulmonary airway malformation, that there isn't cartilage within the mass in the microscope. There are presence of mucosecreting cells. There is significant absence of inflammation. And if you looked at fetal CCAM specimens, there is decreased apoptosis and increased cell proliferation. Probably there is an abnormal signaling of the alveolar cells, which increases their proliferation. The incidence, as I told you before, is quite uncommon. It's 1 in 25,000 to 35,000 live births. CPAMs constitute around 30 to 40% of all developmental lung anomalies. And because they're associated with a high incidence of associated anomalies like cardiac, GIT, spinal abnormalities, that some 14% of these children are stillborn. And one of the commonest postnatal presentations is respiratory distress. But what's happening is, and so there have been attempts at classifying these lesions, which started with Stocker in 1977. And most of these classifications have attempted a pathological classification of CPAMs. But Stocker's classification is still quite widely used. It is a pathological classification. It does not help with stratification of patients for treatment. But I think for completion's sake and for postgraduate sake, it's worthwhile knowing what Stocker's classification is. So Stocker's classification, it was classically classified CPAMs into 3 types. The type 1 was large cysts, type 2 smaller cysts, type 1 constituted one of the most common types of CPAM seen. Type 3s are microcystic lesions, solid to adenomatoid, and these are the ones that can cause solid mass effects. The commonest type with associated abnormalities seems to be type 2, with high incidence of cardiac, renal, and chromosomal abnormalities. But then later on, Stocker's classification was added, 2 types were added to Stocker's classification, type 0 and type 4. Type 0 was an early abnormality. There's an acinar dysgenesis or dysplasia, and it's rare, and it's generally incompatible with life. While type 4 are seen much much later in gestation. They are peripheral, large, thin wall cysts. The commoner presentations with type 4 cysts are pneumothorax and pneumonias, but many of them are asymptomatic. Now, the problem with the Stockers classification was, from a clinical standpoint, like I told you before, is that it was very difficult to stratify these children clinically on the basis of Stockers classification. One. Secondly, you could come to a Stocker classification sometimes on the basis only of the basis of a post resection specimen. There were other classifications that were proposed by Shah et al., which are again pathological classifications like pseudoglandular or canalicular, depending on what they thought was the time at which the growth arrest happened. Krieger et al., again, provided a group 1, group 2, and group 3 based on a pathological classification. To overcome those limitations of pathological classifications and to provide a clinical risk stratification, Adzik proposed that the CPAMs be classified into two types: macrocystic with multiple large cysts, which were greater than 5 mm in diameter, and microcystic with smaller cysts, less than 5 mm in diameter, with the intention to divide the types of CPAMs into those amenable to various types of prenatal and post management. The prime advantage of this classification is to stratify patients into prenatal groups and to plan treatment, if possible, for prenatal management in these children when they presented to the clinic. What earlier on, or at least when we started dealing with CPAMs, most of these were postnatal diagnoses. Children would present with an incidentally diagnosed mass on routine imaging, or they would present with respiratory distress after birth, and the diagnosis would be made then. With increasing skills, increasing ultrasonological skills, increasing quality of the ultrasound machines available, with the availability of routine use of fetal MRI, the diagnosis and the characterization of these lesions have improved by leaps and bounds in the last 2 to 3 decades. So one of the most common presentations nowadays is an antenatal diagnosis. When coupled with MRI, then antenatal ultrasound, can provide very accurate anatomic and size characterizations. It can provide the extent of the lesion. It can provide accurate information on mediastinal compression, mediastinal deviation. It can provide accurate information on the blood supply of each of these lesions and help to differentiate between these potentially phenotypically overlapping masses. So differentiation between a CCAM and a bronchopulmonary sequestration is much easier nowadays with better ultrasound Doppler techniques, and the presence of and the routine evaluation with a fetal MRI. Also, it's important that we are able to diagnose these children early enough in the pregnancy so that we can monitor the progress of these lesions as pregnancy advances. We know that CPAMs generally have a very unpredictable course regarding growth and complication generation during fetal life. A significant percentage of fetal CCAMs between 28 to 32 weeks of gestation will regress, not cause any complications, and these children generally have a very good outcome. A small number will disappear. Regarding disappearance of CCAMs, many people are of the view that many of those so-called disappearances actually are not true disappearances. What happens is the nature of this lesion changes, and as time goes by, the echogenicity of the mass changes, and even an existing lesion becomes echoic with the surrounding lung parenchyma and gives an appearance of ultrasonic disappearance. And hence, the recommendation on this basis is all children with a diagnosed CPAM antenatally need to be diligently followed up postnatally, whether or not they have shown complete or incomplete regression. So one of the other modalities, so in and as we have gone along, we've tried to, apart from a phenotypic classification into a macrocystic and a microcystic, there have been other parameters that have been developed in the monitoring of a CCAM. One of the most popular parameter or an index used to monitor a CCAM is this CCAM volume to head circumference ratio, as proposed by ABSIC's group. So this ratio is a calculation of the CCAM volume, which is measured by standard ultrasonological technique of measuring the height, the length, and the width of a sphere or of an ellipsoid lesion and multiplying it by 0.52. And that volume obtained is compared to the head circumference, and a CVR greater than 1.6 is a single most important predictive risk for hydrops. Of late, a CCAM mass to thoracic ratio of more than 55% also seems to be prognostication value or a high risk prognostication indicator. So many people use a thoracic CCAM mass to thoracic ratio, but CVR estimation still remains one of the most common indices used to monitor the progress of and prognosticating these children with fetuses with CCAM. So one of the gray areas in management of these fetuses with CCAM is still the indications or crystallizing the indications for fetal intervention. In the late 90s and the early 2000s, there was a great, especially a push from the Philadelphia group, the CHOP group, for very aggressive fetal interventions for children who presented with CCAMs, especially those with hydrops, or ones without hydrops, but a progressively increasing CVR of 1.6. And where they thought that those were the kids which were at a higher risk of progressing to hydrops. The problem with hydrops is we know that fetal lung lesions, the fetuses with lung lesions and a CVR with hydrops, untreated, have a very, very high intrauterine mortality rate. The mortality rate goes up to 95% of those untreated. So the CVR at presentation, presence of hydrops. I'm sorry, I'm losing my, as I said, I think I'm getting more and more. Am I heading in the right direction? No. Yeah, so a high CVR at presentation are one of the more important predictors of fetal demise or fetal morbidity that are currently available to us. Now, what happens when we see a child who we think, what are the modalities of fetal intervention that are available to us at this point of time? A serendipitous finding has been that maternal steroids, a course of maternal steroids, seems to help reduce hydrops and CCAM size, and significant evidence is accumulating that although the mechanism of action of maternal steroids in reversing hydrops or reducing CCAM size is not available, there is a role for maternal steroids as the first line of treatment in children who seem to be qualifying for some form of fetal therapy. So a large dominant cyst, significant mediastinal shift, early, a high CVR greater than 1.6 or progressively increasing CVR to develop beyond 1.6, onset of hydrops, onset of polyhydramnios are seen as some of the indications which seem to mandate fetal therapy. The first line nowadays seems to be a course of maternal steroids. The typical course of maternal steroids is 12 grams of betamethasone, a single dose for 2 days. And This regimen can also be repeated multiple times or 2 or 3 times before progressing to other more radical forms or more invasive forms of fetal therapy. So that seems to be one crystallizing as one of the first line therapies in for reducing fetal size or reducing height drops. Now, if there is a dominant cyst with or without height drops, the option is a single shot thoracocentesis, a ultrasound guided needle aspiration, or placing a thoracoamniotic shunt. But these are generally done in fetuses between 20 to 32 weeks. An intervention too early, before 20 weeks, seems to have a significantly high risk of inducing thoracic wall abnormalities. Beyond 32 weeks doesn't seem to be helpful. So if there is a progressing mediastinal shift, development of pulmonary edema, development of height drops, increasing polyhydramnios, a thoracoamniotic shunt has been shown to improve perinatal survival in these patients by reducing the size of the shunt and decreasing pleural effusion. There are significant complications associated with this procedure. There are fetal morbidities. There are maternal morbidities. Shunt infections, shunt migration, shunt slippage, associated injuries, and are commonly seen with thoracoamniotic shunts. But they seem to have a role in managing a large macrocystic lesion with progressing morbidity. Some people have also, especially the CHOP group, have indicated that with increasing height drops, failure of thoracoamniotic amniotic shunting, more solid lesions not amenable to thoracoamniotic shunting, a fetal resection, an open fetal resection can help improve perinatal survival. This requires, as is obvious, requires a multidisciplinary team. Its expertise needs to be available, and as we all know, this facility, there's only a very few centers across the world are capable or have the expertise to perform this sort of open fetal resection inside of for fetal CCAM. This also has its own problems. It's not as if a fetal resection, once completed, has a very rosy outcome. There is significant maternal morbidity and fetal morbidity. Occasionally, fetuses have died intra-op from a sudden decompression of the thoracic cavity by removing the CCAM with, it's akin to sudden decompression of a pericardial tamponade. The child develops reactive bradycardia, cardiovascular collapse, and intraoperative death. So it's not as if these interventions are without their own risks. But the argument for this is this child, these are the fetuses would have a 95 to 100% mortality anyway. So a fetal resection does help to improve the mortality to approximately 60 to 75% perinatal survival. In children in fetuses with more solid lesions or microcystic lesions, which are not amenable to thoracoamniotic shunting, and short of trying to do an open fetal resection, many centers have tried ultrasound-guided lasers, RF radio frequency ablations, and sclerosant injections in this microcystic CCAM with variable degrees of success. The problem with this is those sclerosant or radio frequency ablations seem to have had an effect or have partial effect to no effect, plus have induced significant thoracic chest wall abnormalities in some of those children. So the fetal intervention that's gaining more and more traction nowadays is, if required, an exit to open thoracotomy and resection of the lobe. So this is done generally if you can pull the pregnancy to around 32 to 34 weeks, you could do an exit procedure, deliver the baby from the uterus on placental support, secure airway, resect the lung, and then deliver the baby. This seems to have a significantly better result than intraoperative fetal resections. So, but having having discussed all the options available to us, we seem to have, at least the recent literature is tending towards a more conservative approach to fetal interventions as compared to the late 90s or early 2000s. And like I said, we have sort of come to a point where maternal steroids seem to be the first line of action rather than a thoracentesis. Maternal steroids have been shown to reverse many of those children who would have probably progressed to an invasive intervention in the fetus and have reversed and has reversed hydrops and CCAM size. So the number of fetal resections have come down. The fetal interventions that are more common now are thoracoamniotic shunts, probably, or ultrasound guided RFA or sclerosant injections. So we are tending away from more morbid and potentially morbid fetal interventions to more conservative modes of fetal interventions. So taken all together, neonatal survival with fetal intervention seems to be around perinatal survival seems to be around 87% in non-hydropic fetuses and only around 69% in hydropic fetuses. Now, those numbers look very attractive. In a group where there is a 95% mortality, for example, what I mean is in the hydropic group, the non-treated group progresses to a 95% fetal demise. And with a fetal intervention, the numbers of survivors go up significantly. So that number looks, on the face of it, looks quite attractive. But there are problems associated with that. And those problems that face most of us are probably, apart from the fact, most importantly, is those interventions are not available to a majority of us practicing in this country. So a majority of the patients who present to you or me I probably cannot avail of an aggressive fetal therapy. Then secondly, fetal therapy is associated with its own set of problems. There is a significant neonatal morbidity. Many of these children require prolonged mechanical ventilation. So the children need to be of a certain weight and age to progress to ECMO if required, and significant a number of these children require prolonged mechanical ventilation or ECMO to survive. There is a potential for significant maternal morbidity in children with prenatal interventions. And before we start espousing the cause for more aggressive fetal therapy, we need to assess, one, the expertise available, two, the possible results, three, a steep learning curve, and four, we should be weighing the indications of fetal therapy against both neonatal morbidity as well as maternal morbidity. So, having discussed in detail, so that is one of the areas which is probably up and coming or evolving. Prenatal therapy is more or less in a phase, at least in most centers across the world, is in a phase of flux and evolution. And we haven't heard the last word about prenatal therapy in CCAM yet. So let's keep watching this space, and probably we'll get better ideas as we go along this path as to how good or how bad fetal outcome is, or perinatal outcome is, how it translates to better neonatal survivals, and what are the long-term results of respiratory, neurodevelopmental, chest wall deformity, etc. How good are we on that front in the long term with these children? So now, what is less controversial, less contentious is the postnatal management. And a large majority of patients who are diagnosed prenatally progress through a relatively uncomplicated pregnancy to deliver at term. All children who have had a diagnosed CPAM, a diagnosed lung lesion during their pregnancy need to be evaluated in the postnatal period. The initial assessment is usually with a 2-week X-ray. And unfortunately, an X-ray, which though is widely available, is probably the least sensitive or specific tool in evaluating these children postnatally. In a large number of cases of CPAP, the postnatal X-ray is unable to demonstrate the lesion, right? So the recommendation is for a CT scan. The CT scan is still the postnatal gold standard investigation to diagnose the residual CCAM in a child diagnosed antenatally with a CPAP. Now, then the question that arises is when to time the CT scan. In a relatively asymptomatic child, there is no rush to expose a small newborn to ionizing radiation. So here there is so most groups would defer the investigation in an asymptomatic child with an antenatally diagnosed CPAP to 3 to 6 months after birth. But the bare minimum of evaluation of a CPAM, antenatally diagnosed CPAM in the postnatal period, is to get a contrast enhanced CT scan somewhere down the line. So the general consensus is that 3 to 6 months is a good time to get a CT scan done in an asymptomatic child. There are no controversies in dealing with a symptomatic child in the neonatal period or in the early infancy with an antenatally diagnosed lung lesion. The controversies are actually in the management of asymptomatic infants. The results of either thoracoscopic or an open lung resection in these group of children are equally good, except for minor differences in cosmesis and a few changes in the winging of scapula. The results, long-term results, the pulmonary results, etc., seem to be the same, whether or not in these symptomatic children, whether or not they have been resected thoracoscopically or by open lobectomy. So that can stay a personal choice. If the surgeon feels that thoracoscopy in a newborn is his forte, is his or her forte, by all means, there seem to be some advantages of doing a thoracoscopy, although the long-term results are more or less the same. The controversy arises when we're dealing with asymptomatic infants we are known to have an antenatal diagnosis of a CCAM. So the camps now seem to be divided into two big groups. One is electively operate all these kids, and the second group is wait and watch. So the elective surgery group tend to evaluate these children around 3 to 6 weeks of age. If there is a CCAM that is detected, then they would like to go ahead and perform a lobectomy. Now, electively at 3 to 6 months of age. The arguments in favor of going in for an elective surgery are that the arguments that are put forward is a large number of them will eventually become symptomatic, develop infections. Pneumothorax can be a potentially life-threatening complication of CPAM, and resection in infancy, early infancy, allows the baby to take a full advantage of the alveolar phase, which continues into 3 to 4 years of age, and maximize his or her lung growth. Now, the other group, the observation group, seem to counter all those arguments with equally convincing arguments. The one is the incident, since it's an incidental finding, it may not require a resection. There is, although not very commonly seen, postnatal regression of CPAMs has been documented, and there are a few reports rather than a large series of postnatal regression, but there seems to be a possibility of a postnatal regression. The natural history is obviously not very clear, and there are risks of operation. Having said that, a newborn or a small infant who undergoes a thoracotomy is at risk of complications, of chest wall deformities, of pneumothoraces, of bleeding, of postoperative bronchopleural fistulas, may require mechanical ventilation, etc., etc. And it seems to be safe, or they feel that it seems to be safe to wait and watch. Now, the most emotive factor which the elective surgery group puts forward is the risk of malignancy. And malignancies, both bronchoalveolar carcinoma and more commonly pleuropulmonary blastomas, have been documented in association with CCAM. But the risks are actually not that high as we had previously thought. So, a very interesting paper was published in 2016 in Journal of Pediatric Surgery, and they put forward a few factors which could help you determine whether a cystic lesion in the lung, predominantly antenatally detected, was tending towards a CCAM or tending towards a diagnosis of pleuropulmonary blastoma. And they put forward a few factors which you could use to bolster your argument for or against a surgery. So, if the child had a prenatal detection of a mass, had a systemic feeding vessel, was predominantly asymptomatic, or had a hyperinflated lung, were the factors that would be more towards a CPAM rather than a tumor like a PPB or a pleuropulmonary blastoma. While bilateral or multi-segment involvement was strongly in favor of an evolving pleuropulmonary blastoma. If you had a DICER1 mutation, which is pathognomonic of a pleuropulmonary blastoma, you would have gone and resected. Presence of a complex cyst and a mediastinal shift would prompt you to go ahead and electively resect that mass because there was a higher risk of pleuropulmonary blastoma. So those are the factors which might help you decide in an asymptomatic infant whether to go ahead and do your resection. So this is from one of our own series where this was a mother who presented to us with a large left-sided CPAM at 24 weeks and at 29 weeks of observation. There seems to be a mild cardiac displacement, but here it has shrunk significantly with restitution of the mediastinum. This child underwent a postnatal X-ray, and this is the X-ray. The child had no respiratory distress on room air. The X-ray had no obvious abnormalities, and this was the CT scan. So, how many in the audience would offer surgery to this patient? So we would like, it would be nice if you had your opinions and we could discuss this at the end of the presentation, right? So the groups for surgery or against surgery in this group could probably have, we could have a discussion as to why the persons who espouse surgery in this patient would do so and why not, if not. So now we come back to this clinical scenario with a 28-year-old primary gravida, 28-week gestation, with an antenatal diagnosis of a right epigenic lung lesion with no hydrops or mediastinal shift. This is a case where I would continue to observe with the understanding that this is a child which has a very high likelihood of either regression or staying stable. And in most cases, even if the lesion stayed stable, the child would grow around it and would not require any aggressive prenatal intervention. But I would still advise regular monitoring, regular follow-up, and observation to document the nature of the swelling, nature of the lesion, its progression in size, presentation, whether or not the child was developing polyhydramnios, pulmonary edema, or any other features of decompensation, right? But you could reasonably reassure this mother that the child would probably be asymptomatic, the pregnancy would be uneventful and progress to term, and you could deal with the lesion after birth. But having said that, and knowing what the uncertain nature of the progression of these lesions, there are challenges in counseling, there are difficulties in prediction, and you would need to inform the parents of all the possible outcomes and in probably a non-alarmist way, right? It's important not to be alarmist in these situations, give them a reassurance, and then keep monitoring. Having said that, I must make a confession. In my entire career as a pediatric surgeon, there was one and only one patient I have advised an early termination of pregnancy or an abortion in the second trimester. And this was a child who presented to us with 24 weeks with a TIFA scan showing a large left-sided CPAM with developing hydrops. And the subsequent scan showed an increase in the in a mediastinal shift with hydrops and polyhydramnios. And that was the child which I gave them the option of terminating their pregnancy, and they took it. And the fetus, the picture I used to have, that picture of the fetus was a grossly hydropic fetus, which probably would have, anyway, had a fetal demise. So that is, so we need to temper our counseling based on the factors that we observe as we progress. The next common entity that we encounter is congenital lobar emphysema, or what's also termed as a congenital lobar overinflation. It is marked by a pulmonary with significant pulmonary hyperinflation. The commonest lobe to be involved is the left upper lobe, and followed by the right middle lobe. The pathogenesis is poorly understood. 50% of these are idiopathic with no cause attributed to them. Some children have bronchomalacia with air trapping caused by passive overinflation or passive accumulation of air within the lobe. An postnatal X-ray, most of these are not really diagnosed antenatally, present in the newborn period or early infancy with respiratory distress. Some of them are diagnosed incidentally and have no symptoms or very minimal symptoms. The investigations of choice are a chest X-ray and a CT scan. Those, both in conjunction, are very, very accurate in diagnosing congenital lobar inflations. Severely symptomatic children require to undergo a rapid thoracic decompression and a lobectomy, but a large number of children will be not as severely symptomatic, will give you time, even if they're symptomatic, will give you time to evaluate, plan surgery, and perform a planned resection. So this is one of the children that we did recently. This has a right middle lobe lobar emphysema. This was done only 2 weeks ago. The preoperative bronchoscopy is very characteristic bronchomalacia, isolated bronchomalacia of the right middle lobe. You can see here it's chinked. If you went back, you could see a very a normal. Just 1 second, please. I can't see the play button here. Yeah. So if you went down, you could see a normal right main bronchus take off. The right upper lobe bronchus is fine. So is the right lower lobe bronchus, while the middle lobe bronchus is chinked. This child underwent a very uneventful right middle lobectomy. Right middle lobectomy. Here's the lobe, and went home in 2 days or 3 days in the postoperative period. So the reasons we had for this child was 5 months old, and the reasons we had for operating were not really severe respiratory distress, but there was moderate respiratory distress since birth with both subcostal and suprasternal indrawing, and the most important clinical feature was severe growth restriction. And this child had failed to gain, so the birth weight was 3.1 kilos, and at presentation, the child was only 3.5 kilos. So that growth restriction and that moderate respiratory distress prompted us to go ahead with the surgery, decrease the work of breathing. Immediately post-surgery, the retractions disappeared. The child was comfortable, went on to normal feeds, and we are hoping to follow up in the next few months, and we'll report back to you regarding the weight gain. Now, how do you go about treating CLE? There is no controversies. All symptomatic children require a lobectomy. The question here is, in CLE especially, whether or not you could go ahead and do a thoracoscopy, or would you like to do a thoracotomy? As time goes by and our expertise in minimally invasive chest procedures increase, thoracoscopy is gaining gradual acceptance in CLE. The classical objection to thoracoscopy in CLE was that an overinflated lung would not collapse, would not give you space for infection, for dissection. The dissection would take a little more time. These children typically have a lower pulmonary respiratory reserve, and you would increase by inducing a tight pneumoperitoneum, you would increase the right to left shunt, which is already present because of a hyperinflated, non-ventilating emphysematosus lobe. So, but Rothenberg and team have shown that thoracoscopy is possible. If you think you can go ahead with a thoracoscopy and you're past that point in your learning curve with thoracoscopy in small children where you can perform a safe thoracoscopic resection, by all means. The advantages that thoracoscopy can give you are better cosmesis, lesser incidence of scapular winging, and that seems the scapular winging is a significant deformity that seems to be different in the thoracotomy versus the thoracoscopy group. The lateral thoracic length seems to remain the same over a long-term period, irrespective of whether you did a thoracoscopy or a thoracotomy. So cosmetically, pain-wise, hospital stay-wise, you would be offering a marginally better outcome to these patients via thoracoscopy. The problem is, the caveat is, doing a thoracoscopy in a child with an overinflated lobe, which is resistant to collapse with a significant pneumothorax, CO2 pneumothorax, is a technical challenge. And if you're up to it, by all means. Now, there are some management pitfalls that young surgeons should avoid while managing a CLE. A very common misdiagnosis or a pitfall is mistaking a CLE, especially in an acutely symptomatic newborn, as a pneumothorax. Placing an ICD drain, and especially if you have placed an intrapulmonary ICD drain by accident, can only make things worse and doesn't improve your respiratory mechanics. You have to diagnose, quickly identify a lobar emphysema, and especially if the child is acutely distressed, may need an early surgery. Acute distress can be worsened by oxygen by high flow nasal cannulae or aggressive ventilation prior to surgery in a distressed child. So these are the children where a tempered approach to aggressive pre-op resuscitation should be taken, and maybe benefited by a quicker or an earlier or more aggressive surgical approach. What we have sometimes noticed is aggressive aggressive ventilation during the anesthetic induction itself is something that can cause increasing distress and cardiac compromise, leading to hemodynamic instability on table, which requires a quick intervention, quick thoracotomy, and delivering the hyperinflated lobe out. The moment you deliver the hyperinflated lobe out of the chest, the respiratory mechanics significantly improve. The compression on the collapsed ipsilateral lobes is relieved. The mediastinal shift is not as acute. The pressure on the contralateral lungs decrease, and the shunts, the function and the intrapulmonary shunting, or the left to right shunt, decreases significantly with an improvement in respiratory mechanics. So in these two situations, with acute worsening of respiratory distress because of ventilation or oxygenation, an early thoracotomy can be beneficial. The other pitfall that we sometimes encounter, and we've seen this recently in our institute, is a bilateral CLE. A bilateral CLE is a tricky condition. The most commonly you would see a right upper lobe and a left upper lobe and a right middle lobe overinflation concomitantly. This particular case that the X-rays I have put up was managed quite expertly by one of our junior colleagues at one of our other branches at Rainbow. This child presented with acute respiratory distress. The left upper lobe seems to be more dominantly inflated. This child underwent a left upper lobectomy, and immediately post-op, the distress worsened. There was a lot of pressure from the intensivists and the anesthetists to do a concomitant right thoracotomy and resect the right middle lobe as well in the single sitting. But the child was quite unstable. A repeat chest X-ray showed a pneumothorax rather than an overinflated middle lobe, a pneumothorax in the right side. Placing the ICD immediately relieved the distress. This child persists in the post-op in the later post-op X-rays, persists to have this hyperinflated middle lobe, but the respiratory status and clinical status improved. The chest tube was successfully removed, and the child stabilized on conservative measures and did not require a resection of the right middle lobe, at least for now. The child has been discharged, and we are awaiting and monitoring this child. And if significant respiratory distress supervenes, we could go back and resect the right middle lobe. In contrast, a few years ago, we had to perforce do a bilateral lobectomy, first the left upper lobectomy, and in a few days, because of unrelenting distress, a right middle lobectomy in the same child, which led to a very good result in the child. But one has to remember that those are the options available. Not all children will require a concomitant resection, bilateral resection, or even in the same admission. But the treatment protocol should be decided by the clinical picture and a proper evaluation of the radiology. So excision of the dominantly inflated lobe should result in stabilization of the respiratory distress, may require a sequential lobectomy, but some children may stabilize with unilateral resections as well. Quickly touch upon some other uncommon abnormal variants which may not require much more aggressive treatment. Bronchopulmonary sequestrations are non-functional microcystic lesions which may either be intralobar or extralobar. They typically do not have tracheobronchial communications and are typically supplied by a systemic artery arising directly from the aorta. A large number of them have associated abnormalities, and a significant percentage of them can also be extrathoracic. Some of them are seen in the upper abdomen as well. An increasing number of extralobar sequestrations are now being diagnosed prenatally. There seems to be a male predominance in extralobar sequestrations. There are a wide variety of presentations, but respiratory distress, most of them are actually asymptomatic. Respiratory distress can be one of the presentations, but many of these actually present with symptoms of associated abnormalities. This is one of the extralobar sequestrations which we manage conservatively. You can see that there is a systemic supply to a left wedge-like hyperdense lesion in the chest. Intralobar sequestrations are also seen commonly on the left. There are fewer associated abnormalities, and symptoms are related to compression of the lung and infection. Some of them actually communicate with the GIT. We've seen sequestration. Many of children with scimitar syndromes seem to have some degrees of some patients with scimitar syndrome, which we have seen have occasion to treat, have had sequestrations, intralobar sequestrations. So what happens to these sequestrations? These on antenatal ultrasound, and more increasingly being seen on antenatal ultrasound, seem to be equidense masses. Some of them may have cysts within them, and those are the ones that may be having a hybrid lesion and may have histological features of a C-cam overlapping with that of a bronchopulmonary sequestration. Some of these large masses can cause significant esophageal obstruction, mediastinal shifts, and cardiopulmonary compromise in the features, can cause hydrops, and these lesions seem to have a more favorable prognosis as compared to those with in C-cam. A large number of pre-clinically diagnosed masses in bronchopulmonary sequestration can also resolve spontaneously. So what we need to do is, in these children, assess associated abnormalities. Fetal intervention is reserved for those with greater gestation rate less than 30 weeks, with hydrops and no other associated abnormalities. Thoracoamniotic shunting with pleural effusion may be an option, but it's not useful if there is no pleural effusion. I could not come across any reports of open fetal resection in bronchopulmonary sequestration. And in most cases, the incidence of fetal interventions in these children seem to be much lower than those with C-cams. What happens with these children is pulmonary hyperplasia seems to be the degree of pulmonary hyperplasia seems to be the primary determinant of outcome. So these children have generally a benign course. They need to be stabilized. Only the ones with symptoms require surgery. The asymptomatic ones can be conserved. Some of them have known to regress even postnatally after auto thrombosis of the systemic vessels, or many of them have been treated with non-invasive methods like embolization. Elective dissection or conservation is a choice that you make. I personally would like to conserve all sequestrations until they supervene with symptoms. The other common lesion that we see that is in the thorax or associated with the lung are bronchogenic cysts. These are usually primitive foregut remnants. They can be either mediastinal or intrapulmonary. Many of them present with respiratory distress, infection, esophageal compression, or airway compression. None of them have been known to regress. A large number of them are symptomatic, and excision is recommended in all of them. Elective or emergency, depending on the clinical situation. So, in conclusion, many antenatally diagnosed congenital thoracic muscles will spontaneously regress before birth. Small minority require antenatal therapy, but then again, the problem with that is that you should have, or we should have had, the facilities and the expertise available for antenatal therapy, and that's not just our country. It's only a very few centers in the world that can provide safe and effective antenatal therapy for these group of patients. There is an eventual risk of infection or malignant transformation in a minority of these cases. The risks of these have to be weighed against the morbidities of surgery, and you could probably then tailor your management plan depending on these factors. Asymptomatic cystic thoracic malformations may be prophylactically excised in the asymptomatic infant, but there are many proponents of a conservative approach, and the results in the long term, in terms of pulmonary reserve, in terms of exercise tolerance, in terms of quality of life, seem to be equally matched between the two groups. Thank you.
Mainak, thank you very much for a very, very nice and very exhaustive talk with all relevant literature and conclusions that have all been listed nicely. I think the slides themselves have a lot of material on them and will serve as a source of valuable information for students preparing for exams, etc. So please note those articles that he has quoted. There are some questions in the chat group. I will take them first, and then we can open it up for people who want to make comments directly. So the first one, it says KSK. Unfortunately, I'm not able to guess the full name of the person. What are the options for asymptomatic CLE? Only radiological evidence, but no mediastinal shift.
So there is a wide group of people, including me, who would tend to, in asymptomatic CLEs without mediastinal shift and some radiological hyperinflation, I would tend to conserve under watchful supervision. Many of these children may progress to developing significant symptoms and respiratory distress, and you could proceed to doing a surgery only if significant symptoms arise. So I would be one of the groups personally, although the pediatric surgery group is divided in opinion, but I would be one of those who would rather conserve in this particular group rather than opt for an elective surgery.
Thanks, Mainak. Then Dr. Amit Sitapara asks.
But may I just interrupt? I mean,
yeah,
so this is one group which may also be one of the small minority where there is a bronchial plugging, mucus plugging, etc. So if you would, and if you want to go ahead with a bronchoscopy at the small risk of precipitating an overinflation, an acute overinflation, you could probably do that. But I would still wait and watch. Sorry for that interruption.
No problem. Next question. I think one of them is related to what you're speaking. One is a surgical one. So I'll give you the clinical scenario first. Large CPAM, predominantly solid type of lesion with single large cyst associated with mediastinal shift and ascites during second trimester. What would be the antenatal counseling in the scenario?
So this is a very, very specific scenario where you're looking at a high-risk fetus. especially since it's in the second trimester and it's progressing to the third. If it's late in the second trimester, progressing to the third trimester, this is a high-risk fetus. This is a group which will have a high risk of fetal demise if left untreated. The problem with us is the options that you can offer to this child, given our scenario, our country, are very few. This is a child in consultation with the obstetrics team and the fetal medicine team. I would espouse a course of maternal steroids at the appropriate time, especially if the lesion is progressing. But many of these lesions, this particular group, even when observed, have shown, statistically shown, a small number have shown to regress. So the options at this point of time are, if the child is showing a high propensity or the high risk factors to progress towards an adverse outcome, and some intervention is mandated, what we can reasonably offer is a course of maternal steroid injections. And multiple courses can be tried depending on the gestational age at which you want to go ahead. So that needs to be in consultation with your obstetrics and the fetal medicine team. I don't know if any of our centers are offering regular thoracoamniotic shunts, thoracocentesis, or even those modalities, less invasive modalities like ultrasound guided RFA or laser ablations of these lesions. So if they are, I think those are options that are open.
The other question that he asks is, what are the strategies to control closed airways during thoracoscopic lung resections, especially in newborns and infants?
Commercially available double lumen tubes are not available. In my experience, in our unit experience, and also in our John's experience, we've never had problems with non-selective regular intubation. A rapid thoracotomy and decompressing the mass, if that is caused, and delivering the mass out of the chest, generally tends to resolve the mechanical aspects of the respiratory distress, with a small caveat that a rapid decompression of the thorax can have its own deleterious effects on the cardiovascular physiology. But usually in children, we've not needed to do a single lung ventilation. Now, the strategies of a single lung ventilation, especially in a child with a congenital lobar emphysema, may be beneficial. And that is things like selective right endotracheal intubation, or a Fogarty occlusion of the left main bronchus, or even a selective cannulation of the afflicted bronchus with a Fogarty catheter and occlusion of the right upper lobe, left upper lobe, or the right middle lobe bronchus could be tried. Personally, I have no experience with that, and we have not needed it, thankfully.
I think there is a question about role of ventilation perfusion scans in asymptomatic CLE and such anomalies. Is it something that you would recommend? Do you see a role for it?
You would expect that the region of the CLE is an area of a VQ mismatch. And I don't think it's, especially if it is asymptomatic, there is nothing much to be gained. You expect that in a child, in a benign lesion like CPAM with a single lobar involvement, even if you had to go in and do a lobectomy, a single lobe excision is not going to contribute or deleteriously affect the ventilation perfusion ratios. And so doing a VQ scan, especially in a small child with otherwise normal lungs and a single lobar involvement, may be an overkill and may not contribute much to the management.
Okay. In case of conservative management, is there a size or percentage of involvement of the lobe? I think as a corollary to that, again, Dr. KSK says, CPAM, in my opinion, is to operate all, even if asymptomatic, except those where the involvement is only segmental, because he feels that the segmental ones have rarely caused problem, and so that's an observation that he has made. And the same question about when do you conserve? Is there a percentage of involvement?
I'm sorry. So the indications for operating or not operating in an asymptomatic child do not border on or do not hinge on the symptoms. They are on a predication, or they are on a predication that there will be symptoms, or if the symptoms occur, may be life-threatening. or that there is a possibility of a long-term complication like malignancy. Now, if you are in that group, there is enough justification for you to operate, while the people who would conserve have equal justification not to, given the numbers of malignancies that happen in association with CPAP, usually, especially unilobar CPAP. So if and both groups have equal justification. So if you can offer a surgery, safe surgery in a safe setting with minimal morbidity or acceptable morbidity, then please, for all by all means, go ahead and operate. I mean, there is enough justification to operate an asymptomatic CPAM as well. It's just that the groups who don't offer it, surgery, have their own justification. So one should be clear in their mind why they're offering a surgery. If you strongly feel, and now that comes down to a certain extent to a personal or a subjective assessment of the risk. So if you strongly believe that these are the reasons why I'm going to offer the surgery, well and good. But the caveat should be that you should be able in your setup to offer safe surgery with morbidity and mortality complication levels at acceptable within acceptable limits. That is the only thing.
Yeah, I think that's an important point. I think there is a lot of debate now about why are we waiting? Why should we shut out everything at birth because we can do TEFs at birth? So I think that's a very valuable point that you have brought about, to balance the immediate risks from the disease versus the morbidity from surgery. However safe we think we are in doing those surgeries and our ability to perform the operation. A couple of practical questions. It's very common that you see antenatally diagnosed lung cysts, baby is born and the X-ray doesn't show anything. At what point would you think about doing a CT scan?
So one is, it is mandatory to do some form of evaluation apart from an X-ray. And the best evaluation is a CT scan. And that is anyway any time between 3 to 6 months. So you probably think that the baby would require some amount of sedation or immobilization during the CT scan. 3 months, if required at all, would be a safe time. You don't want to expose a small newborn, growing newborn to a ionizing radiation. But yes, sometime or the other you need to do it. The 3 to 6 months in an asymptomatic infant seems to be a reasonable time to evaluate with the CT scan, and then plan surgery if indicated.
So going forward with the same thing, how much is it always a lobectomy? If you have a peripheral lesion, can you do a wedge resection or a non-anatomical kind of resection? Or do you have to take out the lobe?
That is a no-no. A segmental resection is a clear-cut no-no, especially in a unilobar CPAM. The reasons are, and we have personal experience with this. Segmental resection, the problem with that is that it's very difficult to grossly make out the margins between abnormal tissue and normal tissue. Leaving behind any abnormal tissue is a sure shot guarantee for recurrence and a need for a repeat surgery. So if you have unilobar involvement, the recommendation is a lobectomy as a bare minimum. A segmentectomy may be advocated if there is polylobar involvement, and lobectomies, multiple lobectomies, may jeopardize the long-term respiratory outcome of the child. So if it is a unilobar involvement, however peripheral and however limited it may appear on radiology, a lobectomy is the bare minimum you should do, an anatomical lobectomy.
Thanks, Mainak. I think that puts it very clearly in perspective. If there are any other comments that people want to make or questions they want to ask, please feel free to unmute yourself and speak up. Those were the few questions that were in the chat box. Please feel free to either raise your hand or unmute and speak, either to make a comment or to ask a question. Anybody? Dr. NCK Reddy is online. Do you want to say anything, sir? Okay, yeah, one hand up. I can't see whose hand up. Please, whoever is, yeah, Dr. Amit, yeah, please unmute and go ahead.
Yes, sir. Thank you very
You
much.
could
Deb,
start
for
your
the
video if
nice-
possible, please.
Let me see. Otherwise, just I wanted,
Yeah, just go ahead. Go ahead. Yeah, go ahead.
yes, wanted to ask the question of that how to control the airway was in terms of after resecting the lobe, how would you like to close the resected airway surgically? That was the intention to ask.
So actually, do you want? Sir, do you want me to answer the question, or are you? Hello.
Yes.
No, he had asked a question, but you told us about controlling, selective intubation of the bronchus and things. He's asking about air leaks.
So
and control of the bronchus after you resect.
After you resect, so I have used. So I trained in a general surgery unit, which was a very strong thoracic surgery unit, and then went on to train in another pediatric surgery unit, which had a lot of thoracic surgery load. And everywhere I have used a sewing machine stitch with proline appropriately sized for the child. So it's always so that I have only one way of closing a bronchus, and that is a sewing machine stitch with non-absorbable sutures, and I've had no reason so far to change my practice. I've had only one major bronchopleural fistula in my entire practice, and that is in a child with severe necrotizing pneumonia with stump blowout, with progressing necrotizing pneumonia, benign disease, malignant disease. I have never had to change my practice. So that is my go-to way of controlling the bronchial stump. No transfixation, not ligation, but a sewing machine stitch. I clamp the airway, divide the lung over the clamp, and go with a sewing machine stitch. Works for me always.
So what is a sewing machine stitch? Sorry, you will have to describe it a bit more.
If you look at me in the video, so that's the clamp. You go with your suture
Around
like
the clamp,
that, and then come over and over, running over the clamp, slide the clamp out tight. The proline slides beautifully. It constricts the airway. It leaves no residual air leaks.
So it's a continuous suture.
It's a continuous suture, yes. You could choose to interrupt it at one of the edges, but I like the pursing effect that gives, which constricts the air.
Okay. Thank you very much. Any other questions?
I think Dr. Pulak Parag has a question sometime.
Indication for maternal steroids, it says in CPAM.
So again, if you have, so let me put it clearly. Indication for, so like we're not sure about the mechanism. It seems to help with reversing CCAM size. It seems to help with reversing hydrops in a selected group of mothers. The question remains is, where do you start maternal steroids? The indications are whenever you think that the CPAM is large enough to probably progress to causing hydrops, or has already caused hydrops, where the CVR is extending beyond 1.6 and progressively increasing. And the only armamentarium you have at that point of time, when you have gone beyond the period where you can legally ask for a termination of pregnancy, is to offer maternal steroids. Rationally speaking, at this point of time, that is the only logical prenatal intervention that is available to us, unless we develop the expertise to offer the other modes of prenatal therapy.
So, one last question is about winging of scapula. I think there was some discussion on that.
Yes.
Yeah, so would you just like to comment? And then after that, I think we'll...
So what happens is, a large group of studies have addressed the thoracic abnormalities that might happen when compare a thoracotomy to a thoracoscopy. And they seem to find that there is a an increased incidence of chest wall deformity in the thoracotomy group rather than in the thoracoscopy group. And the abnormality that is significantly higher in the thoracotomy group is winging of scapula rather than reduction in chest volume. And so how they would measure the reduction in chest volume is the lateral length, the vertical length of the chest wall on both sides, and they should be symmetrical. So reduction in the ipsilateral length of the chest wall seems to be another parameter for chest wall deformity, which does not seem to be significantly different between the thoracotomy or the thoracoscopy group, but winging of the scapula seems to be significantly more in the thoracotomy group rather than in the thoracoscopy group. So that's the point why I put up the winging of the scapula as a parameter.
Okay, Mainak, I think before we wind up, thank you very much. I think that was a very, very informative session. It has covered a lot of ground, as I mentioned previously. It will be very useful. So thank you very much for that, because you've taken a lot of effort to put together all these things. And, so thank you for your time, and thank you for your talk. Before we wind up, I just want to remind people that the next session after 15 days will be by Dr. Vikesh Agarwal, and he's speaking about something that is close to his heart, which is basically learning curve in MIS. We are hoping that it will be a more interactive session, so I'm requesting, giving advance notice, and also requesting younger colleagues, especially those who are starting out on the learning curve, to be there for that session and discuss aspects that will be put up during that time. So Dr. Mainak, thank you very much for your time and the effort and your talk, and thank you everybody else for your participation.
Thank you very much.
Good.
Thank you for the opportunity, sir.
Thank you. Thanks. Good night all.